governing body meeting, and we're using this opportunity to also combine our annual general meeting as in our presentation of all the work that's happened over the last year. There's quite a lot of stuff that we'd quite like to go through this afternoon, and obviously some important areas to discuss and explore. But we are going to start the meeting presentation of what has happened over the year that's been, and we are then going to go through our reports, accounts, but also have an opportunity for questions from the public. I should just start by introducing myself. I'm Mark Dorden. I'm a GP and I chair the CCG, and as I say, for this purpose I'm going to be chairing us through the meeting this afternoon. If people can use the hands up function or the chat function if you do want to make a comment when we get to the questions from the public, that'll be really helpful just to know where to when you want to come in. So my understanding is that the way that we're going to run our presentation is we're going to start straight off with that, and I think the slides are going to be shared centrally. I'm going to start us off on that, and if we're ready to go for that, that would be great. There is quite a lot of material in here, so I appreciate there's a lot of information to go through, and therefore for that reason it may be helpful if we can, whilst taking questions in the chat function, it may be that we want to get through the majority of the report and then be able to turn the slides off to be able to take those questions and discuss issues raised, if that's all right. I'm actually going to kick us off, so I don't know if you want to go to the next slide for us, Neil. And as I say, I'm just going to take us through some of the parts of the year that's been. Quick bit of housekeeping that we've mentioned most of these bits, but it's perhaps also just worthwhile mentioning that we're recording the session just so that those that haven't made it, particularly members of the public that might want to see what we've been up to over the last year, can do so. This will be then stored on our website to enable people to join in who haven't been able to make it. If we go on to the next slide, I'm always really keen to start off with patient stories. And over the last year, it's been a really tricky time for so many people with COVID, with all of the different aspects that we all know about. I guess I wanted always to start off with a positive message, though, because there's been some fantastic transformation that's happened over the last year. And this is an example that's from my own practice. One of my patients, not the real photograph that you see here, who's a paramedic. He had been working night shifts, found it very difficult in the past to manage to see us in primary care when his night shift meant that he was actually asleep for all the hours that primary care was open. With the new technologies that we've been able to adopt over this COVID period, he's actually able to send us an e-consult from when he finishes his shift just before he goes to bed. He was able to raise the issue of the suspected infection that he had, and we were able to sort that out in the daytime, organise some antibiotics for him, and then send him a plan by text and respond to his needs. And he was really grateful in the sense of thank you message when he woke up and after the practice had shut. And I guess there are many examples where COVID, however difficult it's been, has led to some real improvements that have benefited some of our patients. And certainly for people like him, a paramedic who's absolutely needed at these times of real pressure, it was great to see we could meet his needs in a better way, more quickly, but also enable him to keep working and not take time off from work. I wanted to share another story, though, because many of our more elderly patients have also had to work in different ways. And a lot of us fear that with concerns around different access to digital tools, whether that the COVID period has been harder for them to work with us. This is another lady that we saw in our practice just a couple of weeks back, and this lady who is housebound is regularly seen by her carers. She has some problems with some leg ulcers, and actually some quite complicated features of that, and needed some specialist input. In the old world, we would have had to go out and visit her. We would have then done a referral to a provider in the community who would then probably have had to link in and get her admitted to see some of those specialists. In the new world, our community nurses were able to use their new tablets that they have and do a video call with us. We were able to look at the problem this lady had, give us some immediate advice to try and help the carers and the community nurses manage her needs on the same day that we were aware of the problem, and we were actually able to send some pictures through the specialist team at the hospital who also managed to respond with a plan within 24 hours. So there have been some improvements for all of our parts of the community, however challenging and how many other difficulties there have been. So I always just want to start off with a word thank you, because thank you to so many of our frontline who have enabled us to meet many people's demands, even if there are problems with many different aspects, as the workload is huge for all parts of our system, and no doubt we'll talk about those bits later on. So if you wouldn't mind just clicking through the word thank you for us, Neil, thank you, and then we'll move on to the next slide. And I guess we want to particularly look back over this last year to not just say thank you for everyone's hard work, but also realise that it is challenging for so many different ways. And winter approaching does mean that we really need to be thinking, is there anything else that we can do, anything else that we can learn from? And I'm sure colleagues will mention later on, we have had a regional session last week, just trying to think what more we can do to prepare for winter and prepare and work together across the whole of the NHS and care services to try and enable us to not just meet the needs of patients, but to still do so within the different ways of working that we have to with the coronavirus still very much involved and very much high numbers of patients and the public around the system that we work with. If we go to the next slide, we do have to particularly recognise, though, the contributions over the last year of people supporting those shielding, those that in the communities have helped one another, and those in the vaccination centres, which have relied hugely on members of the public and other members of services working in very different roles to meet the needs of our vaccination work. It really has been a heroic effort by so many to enable this to work. These are some photos from the Gateshead system, and on our next slide we have some photos from the Newcastle system. And we've obviously done some huge work trying to get these centres up and running, and those centres are now starting to do the work on booster jabs, as well as trying to give the third vaccines for those that are immunocompromised. And this is in conjunction with a huge rollout of all the flu vaccines at the moment. So a huge debt of thank you to many people involved, and there are many people behind the scenes who are not always visible that we are very grateful to. If we keep going down the slides, if that's all right. We just then wanted to pass on to Joe, who's going to take us through our and finance information, and then we'll come back to some place-based updates. So over to Joe.
Thanks, Mark. And just for those who don't know me, I'm Joe Corrigan. I'm the Chief Finance and Operating Officer at the CCG. So there's probably a couple of slides just focusing on the non-financial performance of the CCG during 2021, and then a couple of slides just picking up headline financial performance for the same year. Can we move on to the next slide? Thank you. I mean, there are over 200 targets that as a CCG the NHS requires us to meet, but if we can just focus on the main NHS constitutional targets for the financial year, in terms of 4-hour waits, we marginally underperformed against the 95% requirement for the year, averaging in terms of our two main hospitals at about 92%. Ambulance response times, similarly in terms of Category 1 response times being 7 minutes, we actually achieved the target averaging around 6.5 minutes, but in terms of Category 2 response time of 18 minutes, we were averaging longer, 26 minutes by way of that key performance indicator. We have seen of late many over 12-hour waits in A&E across the NHS, but for us in 2021, we had no over 12-hour trolley waits for the duration of the financial year. We have, and we'll talk throughout this presentation about the impact of the pandemic, and we've particularly seen adverse impacts arising in cancer waiting times across the service, and there is a slide further in the presentation that will just shine a spotlight on that, so I'll just pause until we reach that point. In terms of hospital-acquired infections, we achieved all the targets required by NHS England, but in relation to improving access to psychological therapies, whilst we had achieved targets in Gateshead, we didn't have a universal service across the CCG in terms of achieving the targets, and we are focusing on improvements of the service in Newcastle. Referral to treatment times, this is the 18-week waiting times. Again, another consequence of COVID, the ability to serve of the service to meet the 18-week waiting time. And again, there are a couple of slides later in the presentation that are focused on this. In terms of mixed sex accommodation, we're actually, for the full year, we did actually achieve the target, so the indicator there is a green. I think it's showing amber because we did have some breaches in early April. Can we move on to the next slide, please? Thank you. In terms of challenges, well, it's well known that in the Northeast, and particularly in parts of the communities we serve, we have significant poor health, and in particular, children who are overweight and obese. We have long times for surgery, and again, we'll come on to some detail in that in a minute. Psychological therapies I've already talked about. We have a reliance on specialist inpatient care that we are trying to address through the Transforming Care programme of work, and we are actually making good progress in caring for people in our communities. We had the recent announcement of funding for the NHS in terms of catch-up, and however, there will be significant workforce challenges that we see as being perhaps the rate limiting factor as we try to address some of the waiting times that I will come on to. Health inequalities. We know that COVID will have a greater impact on deprived communities, and we'd expect health inequalities to widen, and therefore will be a focus of our work as we go forward into the new ICS. And in terms of the vaccination programs and flu, we continue in our planning work in terms of implementation of the next stages of the vaccination program as we head into winter. And the final point there, again, recognising the high levels of inequalities in terms of smoking, obesity and alcohol consumption rates amongst our communities. Next slide, please. This is just a RAG rating or a red-green rating in terms of cancer performance across the tumour sites down the left-hand side. And we can see just across all of the cancer providers in the northeast and North Cumbria that there is significant underperformance in many of the tumour sites, and again arising from the challenges of COVID and the consequences of trying to manage the pandemic. And this is something that is of prime importance to us in terms of recovering the cancer pathways. Next slide, please. Similarly, in terms of our waiting list and waiting times, here we can see a time series of the numbers of patients that are waiting in terms of our waiting list by all the providers. And we can see there was a dip at the start of the pandemic, but since the pandemic we can see the position has significantly deteriorated to worse than pre-pandemic levels. Next slide, please. This one shows over 52-week waiters. We can see again pre-pandemic we had no over 52-week waiters, but during the course of the pandemic the waiting times and waiting lists have increased significantly, and you can see there we have now waiting times, long waiting times that we haven't seen for over a decade. Next slide, please. In terms of our annual accounts, next slide. In terms of statutory financial duties, just to remind the governing body that these are that we spend no more money than we're actually given. We actually take into account directions from NHS England as to the types of funding that we're giving and the purposes for the funding that we are given, and that we spend that money according to the directions issued by NHS England. We publish an explanation of CCG expenditure on quality, and that's contained within our annual report. And we keep appropriately accounting records and published annual accounts for which we are audited. And we do have an obligation to pay our creditors within 30 days and to adhere to financial targets set by NHS England. Next slide, please. So in terms of our annual accounts for 2021, we achieved an unqualified audit opinion, which is good. It's a clean bill of health. And we submitted the accounts to NHS England by the required deadline. And we have actually published on our website the annual accounts and report. Next slide, please. In terms of meeting the statutory responsibilities, we did meet the break-even duty. We started the year with a planning commissioning budget of just over 800 million, and with other additions too, including the primary care commissioning budget, we had a start a financial envelope of nearly 900 million. However, we then entered into a financial regime due to COVID, and I'll talk a bit more about that in the next slides. We are still in this COVID financial framework that in essence set out for the first half of the year block contracts across the service for our NHS providers and specific arrangements in terms of key areas of expenditure around the hospital discharge programme, and we can see this financial regime continuing in the current financial year. Next slide, please. So in terms of the year end for 2021, we ended the financial year with over £1 billion of resource, and we underspent by 1.4 million, and that surplus was a surplus set by NHS England. So overall, we spent 99.9% of the £1 billion that was allocated to us for the financial year. Next slide, please. That's just another representation of what I've said, so let's move on. In terms of the obligation to pay our creditors within 30 days, both in terms of volumes and cost, we achieved in excess of the 95% target. So on all measures, we've continued our success in terms of the obligation. Next slide, please. How the money was spent, I always find the next couple of slides of interest in terms of how we spent the money and with whom. We can see the greatest amount of money that we'd spent during 2021 was on general and acute services, just under £500 million. As we wheel round from sort of 12 o'clock, the next section of the pie, the sort of amber or orange section, is mental health service, 119 million. The burgundy section at 7 o'clock is prescribing and some aspects of primary care commissioning funded out of the hospital elements or HCS elements of the programme spend. And the turquoise section at 9 o'clock is our continuing healthcare and complex care packages that we have in our community, 105 million. And then the final bit to focus on is probably the olive section at 10 o'clock. That is the delegated budget, the primary care co-commission delegated budget from NHS England. So if we combine that with what we spend on prescribing and other aspects of primary care through enhanced services, we spend around £187 million on primary care services. Next slide, please. Just looking through a slightly different lens in terms of by provider. Again, sort of wheeling round from 12 o'clock, the first segment of the pie chart, the blue segment, is Newcastle Hospitals, 274 million or just under 274 million. Wheeling round, Gateshead Healthcare is 163 million. And in terms of the olive section, it's continuing healthcare at about 104 million. We can see the violet section is primary care contracts, which is about or just over 90 million. It is a similar level of spend with Cumbria and Northumberland Town and Weir Mental Health Trust, which is the next section at 10 o'clock. Again, similar, just over 90 million pounds. So those are the major areas of spend by provider and by commissioning line. Next slide, please. This is always, again, of interest. It's a time series since we came into being in 2013-14. Again, how we spent the resources in a time series by sector. So you can clearly see both sort of pre-COVID and during COVID that the acute hospitals is the most significant areas of spend. And we can see there through the pink line just the impact on expenditure of COVID. As we scan along, we move into mental health and community services, and again, it just illustrates the gear and effect of expensive hospital care with cheaper community-based care in terms of how we spend the money. Probably the most significant there, just focusing on continuing healthcare, we can see a significant rise in 2021, and that's predominantly due to the hospital discharge scheme. Next slide, please. Looking ahead, I mean, this slide really just repeats what I've already said in terms of the continuation of the COVID financial environment. We are expecting a second 6 months to take us through to 2022 to be announced within the next day or so, if it hasn't already been announced, but certainly announcement is imminent. Next slide, please. Looking ahead, I mean, clearly we are moving into a larger ICS where our resources will be absorbed into the resource envelope for whole of the ICS that will cover the North East and North Cumbria. So again, that's something that we need to think about and make sure that as we close down this organisation, we close it down with a clean bill of health and no liabilities for the new organisation. I think that, yes, that concludes me, Mark. Thank you.
Thanks very much, Joe. And so we're now going to turn to a time of place-based updates. But just before we do, David's going to take us through some other parts. Over to you, David.
Yes, thanks very much. Can you move to the next slide, please? Okay, so this is a photograph from another era where people gathered in rooms and learnt and sat way too close together. But to highlight really that public and patient involvement has continued despite the fact that we've been unable to do it quite the same way. A significant amount of work's gone on by a variety of means to ensure that we continue to listen to our public and patient population. Next slide, please. So there have been several initiatives that have taken place across Newcastle Gateshead area. One is supporting practices to become more accessible for British Sign Language and deaf and hard of hearing patients, with the development of an implementation of guidance to practices to ensure that they're compliant and provide that degree of access. There's also been engagement on the transformation of community mental health services, with a particular focus on identifying experts by experience from the public and really taking their experiences and ensuring that the design of services going forwards really draws on what they've experienced and, as I say, on their expertise. We've worked with practices to look at the patient participation group toolkit. This is again about trying to ensure that practices listen to their patient population, and the tools for them have been out for just over a year now, and we continue to fine tune those and encourage practices to use them. Next slide, please. We've hosted some ongoing meetings looking at long-term conditions with the patient expert group. And again, along the same principles with the mental health, it's about really listening to patients who have a variety of long-term conditions and working out how we can improve our services for them. And finally, there's been the the engagement through the online resources, which is obviously many bits of our working were pushed online, and it was really important that we, as I say, we didn't lose touch with our patient populations, and online forums have been incredibly helpful and indeed very popular, and have actually going forwards will provide another string to our bow, ensuring that we hear the patient voice in the design of services going forwards. Next slide, please. So if I can move on to talk about Newcastle Place. So just to introduce myself, I'm a Newcastle GP. When we talk about Newcastle Place, the place really is just a way that we're currently describing geographical areas where agencies come together to try and coordinate their care and services for patients. So for Newcastle, we're really talking, for Newcastle Place, we're really talking about Newcastle. So that's really the sort of geographical area that we're describing. Next slide, please. So the system of place working in Newcastle is really built around the collaborative Newcastle arrangement. So this is about people working together, predominantly the local authority, the CCG, our big trusts, the Newcastle Hospitals and the Mental Health Trust, but also a variety of other partners from the university to the GP Federation to the voluntary community sector, but not just working together, actually for the key partners having a legal collaboration agreements in place. And this really gets some teeth and some momentum into that joint working. On the right hand side, we were able to identify what is the sum total amount of resource available in Newcastle, and we come up with this unforgettable number of 666 million. And from there, we're able then to see where might we pool resources, where might we align what we're doing to make sure that the joined up processes provide the care that our patients need, and at the very least, can we not just see each other's budgets and understand what we're capable of and what we can bring to the table. So these arrangements provide that degree of transparency, but also because of the legal nature of them, provide some teeth to them. Next slide, please. So the priorities have really been, of course, around the COVID response. I guess it's been everyone's priority, regardless of which bit of the system you're in. And certainly this has been very much a collaborative process led by primary care in the immunisation programme, but obviously every bit of the city has had to come together to tackle this huge challenge. But we've also managed to carry on some other work, and we'll continue to do so. So the work around Newcastle neighbourhoods, again, working with partners across the collaborative Newcastle membership, looks at how we can improve care and social care to patients and residents at neighbourhood levels. We've also done some work and are doing work around the duplication to personalisation agenda, which is a not particularly catchy title, but it's really recognising that actually some patients and residents present in multiple ways and multiple times to different parts of the system, and actually that creates confusion, that sometimes creates that duplication. And what we really want to do is move away from a sort of one-size-fits-all response, but to a personalisation agenda, where we can try and streamline the pathways that patients experience, and that provides better care, but also more efficient care. The Children and Families Newcastle agenda, this has three components. This is around, again, integration of services. It's around providing centres which we see as magnets, i.e. places where parents and carers choose to go, and whilst they're there, being able to provide a range of services for them under one roof, and at the same time development of a family partner model, which is a new individual under the collaborative Newcastle arrangements, so not a healthcare worker, not a social worker, but someone who can cross that divide, as it were, but at a very upstream level, providing a first point of contact for many patients, for many parents and children and young people. The other priorities going forward are around mental health transformation. Again, really with a similar theme around integration, around working early with people when they first present with challenges. And again, that works at both a neighbourhood level and, of course, feeds into the work of the Children and Families Newcastle models as well. Homelessness remains a key priority for the city. It has been for many years, and we're doing some work looking at some of the more complex patients and residents for whom bricks and mortar aren't the only solution, that their lives are more complex. The reason for the homelessness requires a multi-agency response, and therefore, again, it lends itself very well to a collaborative approach. And finally, integrated local care model. This is really trying to look at how particularly primary care, urgent care and community care services can work better together, as particularly with pressures in the system. The last thing we want is for patients to find themselves rattling around between different bits of the system or falling between the cracks. And so we really need to try and bring all those different strands together to provide that more integrated approach. Next slide, please. Key achievements, well, I've used the phrase several times already: integrated service delivery, working together to try and ensure things go smoothly and most efficiently. We've also had a leadership programme going, which allows leaders from different parts of the system, the workforce, to come together and learn together, work on projects together, and that helps to overcome any sort of organisational cultural barriers, improves understanding, and will build on that collaborative approach. The command centre is a way of gathering the data so we have a real-time sense of where we are. How many beds, hospital beds, do we have in the city? How many patients are waiting for discharge? What's our care home capacity? And going forwards, we'll hopefully build into this the primary care capacity and stresses in that bit of the system, because that's currently is a missing piece of the jigsaw. We're also looking at the thinking more about the Newcastle pound, and I mentioned that figure of 666, but working together on that basis within Collaborative Newcastle, but also aligned to the Health and Care Collaborative Newcastle groups is the Growth and Prosperity Group, with its focus on jobs and economy. And again, working from a health and care, working into growth and prosperity, we start to have much more joined up conversations about how we can most effectively and efficiently use the Newcastle pound. Thought leadership based on the human learning system is really about how we move away from thinking about this is what the service does, how does the patient or resident fit into that, to thinking about how we develop bespoke responses to the needs of our resident population. And finally, the COVID benefits and legacies. A lot of work has gone on. The Lighthouse Laboratory now doing up to 80,000 tests a day. There's a science bit of that, looking at how we can improve the testing process, and as well as support to public health and local authority colleagues in developing local responses. Next slide, please. Key challenges: system pressures and recovery are obviously going to be huge. We understand the waiting lists are going to take time to come down, and we're working with all partners on these to tackle that. Tackling also inequalities, which remain significant within the city, and the COVID pandemic has, if anything, put greater pressure on those inequalities, and we need to urgently address that. As we move and consider the integrated care system that's going forward and the loss of the local CCG, we're really keen to ensure that the primacy of place, that we don't lose our local health voice into local arrangements, that it doesn't become subsumed into a larger ICS, and we remain confident that we can keep that place focus. Sustainability going forwards generally, and I think also measuring impact. How can we be sure that all the things that we're doing are having the impact that we want them to do? And that remains a key challenge for us. Next slide, please. Thank you, Mark. I'll pass back to you.
Thanks so much, David. So, folks, we're nearly through this presentation. You have two more sections to go. Myself just talking from the Gateshead system point of view, and then Mark's going to come and give us a bit of a regional perspective in terms of the work in the integrated care system. Next slide, please, Neil. We in Gateshead have also had a similar place-based evolution, and much of the information here is similar, but obviously from a Gateshead perspective. I happen to hold the role of chairing the Gateshead Health and Care System, and on that link you can see when we circulate the slides, you can click through and find the information around some of the work that we'll refer to in that. If we go to the next slide. So Gateshead Cares is the brand that we use for the Gateshead collaboration, and we start from the bottom of trying to serve our public and trying to think of the key priorities that we want to focus on as a system, and this is in addition to all the many different ways our organisations are serving our individuals across Gateshead. If you start from the bottom left, you'll see that we have had a lot of great work trying to bring together the best start in life, trying to help particularly with a focus on children, young people, which is what the an acronym stands for, and many apologies for any acronyms that you see or hear about in this presentation. Please do ask in the chat function if there's any that you don't understand. So this particular work is for SEND, the special educational needs that those children and young people may need more coordination particularly, and so we wanted to focus particularly around that, and there's been some fantastic work trying to coordinate and build on some great practice already happening. At the next, the other end of the spectrum, we also wanted to recognise that our older people, particularly those with a lot of frailty and most often in care homes, are often in need of our services being delivered in a slightly more integrated way. So we've been reviewing the whole way that care homes are commissioned, and then the model of the programme, and that's been a great bit of work that colleagues have been coordinating, and at the same time still trying to think, whilst the model is being reviewed, is there better ways that we can actually support the frailty itself, particularly with deconditioning over this period of COVID and activity levels being lower. And it's great that across the region, and often started in Newcastle and Gateshead, is all the work that's happened on the How Fit work to try and increase the exercise levels in our older people. Mental health more broadly has been a real priority, recognising the increase in need over the COVID pandemic. And then lastly, the right hand of the yellow boxes are PCNs or primary care network development. We've realised that if we are really serious about localities developing as primary care networks, we need as a whole system to support that way of working, not just the practices. It has to be all of us trying to think what we can do for our public and for our patients. If we go up the diagram, those are all coordinated in our health and care delivery group, and they in turn, all of that delivery side then moves into the health and care system board, the green box, and that's where we coordinate a lot of the engagement, working with stakeholders and trying to make sure that we actually have the views of the public and patients through our colleagues in HealthWatch, who you can see in the maroon coloured box on the bottom left of the green box. If you work around there, we have representations from our voluntary sector, and we are hoping to propose that there may be a professional advisory group, which we're exploring. That one is not in existence yet, but we do very much link to partner organisations. And then if we go to the top, our health and wellbeing board receives regular updates and will ask questions and give a bit of scrutiny to the work of the health and care system board, so that our politicians and members of the public that attend that can be very much involved with the work that happens across Gateshead. Again, on the top right, not quite involved as we talked about our integrated care system. We very much want to make sure we have good ways of working with them, but obviously that is still a work in progress. And then to the right, we have a health and care leadership group. So there's a smaller group of our leaders of our key organisations that come together to see if they can unblock problems that are happening with delivery or other parts of the system. And then lastly, as we mentioned before, our primary care network, we also have a strategy group for that, which links in. And I appreciate there's quite a lot on that diagram, but hopefully that gives you a flavour of what's happening within Gateshead. If we go to the next slide, we wanted to mention just three particular parts of the work that's happening in the Gateshead Cares Alliance. Firstly, engagement. We absolutely want to engage with people in lots of different ways, whether it's delivering their care, or how we organise their care, or as I say, in any other angle that we can mention. And these are some particular focused ways that we've done that. These are some examples around children and young people, some of the work we've done with our mental health work, and some that's been done with our long-term and conditions work. But as I say, in all of this, we often coordinate it through our health and wellbeing board, so that there is a public record of all that's happening and an opportunity for members of the public to be involved in that work too. If we move to the next slide, and this is just describing some of the key relationships we have in Gateshead. We've had for a long time something called the Gateshead Care Partnership, where we bring together providers of healthcare to try and think about how they coordinate the delivery of community services, recognising that community services, as in community nurses, and some of the specialist services that happen in the community need to link in really well with local authority, primary care and specialised services, and those from the voluntary sector and those in mental health. And our Gateshead Care Partnership has been able to do that, and that work continues to evolve. But we want to then make sure that we can integrate all of our commissioning teams as well, so that the CCG team and the local authority team really does work as one integrated Gateshead team. And that's been a real success over recent times, with a number of joint appointments, a plan on the page, and a one-team approach. All of this combined with our providers, our commissioners, and those representing our public, patients and other stakeholders comes together in our Gateshead Care Alliance. And we, like Newcastle, have involved a legal agreement to try and make sure that everyone is really serious about commitment, and we're able to then have a revision of that plan each year. A lot of this, again, like Newcastle, has been based on this human system learning, and very much trying to see how we can give new opportunities and new ways of working, and trying to make sure that we can listen in new ways. We also have followed Newcastle's lead on the leadership programme, and that has enabled a bit of collaboration in the way that our leaders across the different systems learn together, and we have some learning ourselves about how that programme continues to evolve. But we have been able to celebrate some of the great achievements over the COVID period in one of the case studies that's been published in the Local Government Association, the LGA, and if folk are interested, that link is there for you as well. Obviously, with all of these great comings together and the relationships that are evolving, there remain many challenges in the way that we continue to evolve. And the next step for most place-based partnerships is to develop their place-based working to form some sort of joint committee where there can be a more formal evolution of that legal agreement to enable true delegation and integration between our different parts of the system. Next slide, please. Clearly, whilst we have all of that engagement work, all of the work around how our system evolves and our key relationships, we absolutely want to keep delivering. We talked about those yellow boxes on the front sheet around these priorities, which are listed again there, and some of the key achievements we've had in delivering for those priorities. We're mentioning the particular three there: the children and young people work with SEND, and being able to be able to share good practice for other areas. Older people, as I say, that work and care home model is going really well, and we are hoping that that will really benefit our public. And the work on our mental health work, we have a variety of plans and different ways of trying to bring that together, and we hope that this really will enable us to integrate things in a new way that we haven't achieved before. Clearly, like all places, we remained hugely challenged by the inequalities that have grown over COVID, by the system pressures that we all continue to mention during the meeting but have mentioned already, and the remodelling of a variety of different settings, not least care homes, but also the social care system, to ensure that we have a sustainable workforce and maintain the workforce in all areas and enable our clinical leadership to be continuing to contribute once we leave the world of CCGs and enter our new ways of doing things in place. Next slide, please. So that's a whistle-stop tour, and I'm going to pass over to Mark to talk now a little bit about how the world has evolved across the region in the integrated care system. Over to you, Mark.
Thank you, Mark. Next slide, please. So I'm just going to talk a little bit about work that's been going on for quite a while now in terms of the NHS's development of the way that the NHS is going to work, which will start to kick off on the 1st of April next year. This work commenced with a white paper and various supporting papers that were published. And the white paper itself was published on the 11th of February, and a subsequent health and care bill was then introduced to Parliament on the 6th of July and has gone through 2 readings in Parliament. And the general thrust of that work is about changing the way that the NHS works, focusing on integration, focusing on innovation, and understanding how we work with partners across the system to drive, particularly in respect of things like reducing inequalities. Next slide, please. So the expectation is that CCGs will come to the end of their lives as statutory legal organisations next year, and they will be superseded by integrated care systems, of which there will be an integrated care board, and that will be established on the 1st of April 2022, and this will be the new statutory NHS body, and the CCGs will be dissolved, and it is the CCGs that will then transfer their commissioning responsibilities to the new ICBs. So there is now a proposed legislative framework, and the expectation is that the ICBs will have very similar constitutions and very similar responsibilities as commissioners to those responsibilities that we currently hold as CCGs. We will retain as CCGs our current legal and statutory duties up until midnight on the 31st of March. And it's at that point that we would then transfer our responsibilities into those new statutory organisations that will come into being. Next slide, please. So there is now a programme of work which is underway. Some of that work is national, some of that work is across our whole ICS area, which covers North Cumbria in the northeast from Northumberland down to Middlesbrough. And work continues to develop our ways of working at a place-based level. And for us, that means Newcastle and Gateshead. In terms of specifics, Professor Sir Liam Donaldson has already been appointed to the chair of the ICS, and various elements of guidance are now coming out to help us understand how we design the ICS, how we design ways of working, and how that ICS, which is quite a large geographic footprint, will work with all of the place-based areas like Newcastle and like Gateshead. There are programme teams in place, work streams established to take that work forward, and engagement events kicking off with partners, and some of those things are already underway to understand how we design and develop this new organisation and the new ways of working. The expectation is that the ICS will have a shadow board in place towards the end of this year. And as I've already said, the hope is that our ICS, along with the rest of the country, they will come into being as new statutory organisations on the 1st of April next year. Next slide, please. The development work streams that are going on now cover a wide range of areas, specifically in terms of the ICS development itself, because it is a new statutory organisation. We have a huge range of underpinning work going on, not least in terms of finance, in terms of human resources, organisational development, ways and means of governance with the new organisation, systems performance and improvement. So all the things one would expect in terms of understanding how this new large organisation takes on board the responsibilities of all the pre-existing CCGs. There are specific elements about enabling, not least in terms of informatics and in terms of the whole digital agenda, and very specifically around how that supports population health management, the analysis of population health, in order for us to have that very, very clear overarching view of inequalities across the whole system to help us make the best decisions that we can for our public patients. You'll also see that there is a work stream there for provider collaborative development. So our colleagues in our large provider organisations, our large hospitals, will be coming together and working together under the banner of provider collaboratives to understand how they can work more closely together, to understand how they can do things more efficiently and effectively together. And that's all very welcomed, given all the discussion that we've had previously about where we are in terms of things like waiting lists, etc. Next slide, please. Some of the very visible work that's going on right now are the national approaches that have been put in place for recruitment. So the recruitment to all 42 ICS chief executives nationally is now underway. Those processes started off about 3 weeks ago. And the expectation is that the incumbents to those roles will be in place hopefully towards the end of October. There are a range of other appointments that will happen hopefully soon after that. And so we can expect to see similar national recruitment processes for the Director of Finance, Director of Nursing, Medical Director towards the end of the year. And all of those recruitment processes are focused on ensuring that we have an integrated care board in place, functioning for the 1st of April next year, 2022. Next slide, please. So I will stop there, Mark, and pass back to you.
Thanks very much. And we've now finished our slides. We have one remaining slide which we can go on to now, which just summarises the challenges as we look ahead from the current system, and these will remain there for the future system. So in a moment, we'll turn to a time of questions. So if you do have any, it'd be great if you could start putting them in the chat function now. We're starting to get ready with your hands to go up. And as I say, we'll come to questions from both our governing body members, but also then to our members of the public. Just to sort of finalise though, obviously lots of challenges for our population. We all know that our population is growing older. With COVID, our health inequalities have worsened, with often those most able managing to cope better because they had access to more resources of various types. We know that our smoking levels, alcohol levels and obesity levels have all worsened again over COVID, but we're already some of the highest in the country. And we know that our pressures in our whole system that we've heard from are still very high, and COVID absolutely has not gone away and hugely influences the way that we can deliver care, not least in the way that we have to still socially distance and follow the infection and prevention control mechanisms. Clearly our transition we've talked a little bit about around both at place-based partnerships and the transition to the integrated care system, and also the close down of the CCG organisations too. And then lastly around primary care capacity and the primary care networks as they evolve. So there's a fair few things happening for our system, and we're really grateful for everyone's support. Perhaps if we could stop sharing the slides now, But as I say, end with a huge thank you from many different people in the way that they've both cared for people over the last year, but also led those changes we've talked about. Are there any questions from any members of the governing body first, before we then turn to any questions from the members of the public? If there are no more questions from the members of the governing body, we will come very quickly. But Liz, do you want to kick us off?
Yeah, thank you for those presentations. I mean, there's loads of information there and questions I could ask. I'd just like to ask two, really. One is, was there any mention in the NHS bill about the woeful underfunding and funding cuts to local authorities? Because if we're working with them, has anything of that nature been raised at any level? Because it does seem a little bit odd to me if it isn't. So that's the first question. And the other thing, Mark, was just about your presentation, which is really about inverse care law and you know, our huge health inequalities. And you mentioned reaching out to underrepresented communities. I mean, and I just wonder if you could actually give us some what's actually happening on the ground on a practical level about that issue, because I think that's a really important issue. As I say, there was loads of important information in those presentations, but that's just my two main questions, please.
Fantastic. Thanks, Liz. And obviously, any other questions, please do come forward. In terms of the funding for local authorities, as I say, I don't know if Joe wanted to mention anything, or colleagues who also work very much with our local authorities had any further information. But I think you raise a really important question that we're absolutely dependent on our services commissioned by our local authorities, and without appropriate funding rises, not least for social care, we absolutely don't see that these pressures are going to reduce. And I think you've summarised it very well, that we are not reassured that the funding increase from central government has been large enough to meet the many needs in our social care and other local authority funding services. I don't know if anyone else wants to comment further on that.
I think it was separately addressed with the revision to the national insurance contributions. I mean, the split, the support between sort of health and social care and the transition over time. I think that was the means by which, rather than the current bill, that the government set out its intentions to try and address the shortfall in funding.
Thank you, but obviously there is lots of concerns that people will think that now the funding issues have been dealt with, now that has been announced, and we all know that the funding raised by that may still not be sufficient for the wider increase in funding that's needed to meet all of the needs that are out there. Shanaz.
I think so. I suppose there's the issue about the funding cuts and those well rehearsed, and we don't have much control over those, do we? What we're left with is actually having to deal with the things on the ground. And I suppose from my perspective, I think the PCN enhanced services give us a really good opportunity to start thinking about what we do on the ground. And there are opportunities in the PEP and in the enhanced services for us to actually identify health inequalities and start to work as a system at a local level. And I think that's an opportunity for us to identify what's important to our patients and actually what are the issues within our PCNs. And I'm really pleased that we've started to connect in with the local authority. We've started to connect in with the with public health. You know, public health have been really, really responsive, connecting in with our federation. So working together at PCN level to address the needs within the population, because the thing for me as a practice manager is, you know, I'm talking more and more about this failure demand, and all of it is landing in general practice. So we've got a choice about sort of getting sucked up with the white noise, or actually doing the little we can on the ground. And I think our PCNs really give us the opportunity to do what we can on the ground.
Thanks, Shanaz. And I'll be honest, Liz, I wasn't sure which Mark you were addressing that to, but perhaps just to let you know that there is something called the Health Inequalities Working Group over the region. So that's just been recently set up, and we have a Health Inequalities Summit coming up. And actually, we've been trying to get examples of where there's been some great practice addressing some of our more disadvantaged group. And one of the examples as a CCG we're going to put forward is the work that's happened in the outer west part of Gateshead, where they've been looking at digital inequalities. There are many other different lenses we could look through, but there are many different examples about how we can understand health inequalities and we can share good practice, but we all know we've got to put a lot more effort into trying to help those disadvantaged for many different reasons be well served in the future. I don't know, Mark, if you did want to provide any other thoughts.
I think that pretty much covers it off, Mark, I think.
Fantastic. So are there any other questions that anyone else wants to ask? Because then I'll perhaps turn to the members of the public. Are there any questions that you might want to ask? And if that is met with silence, that is absolutely fine. We will continue to our next parts of the agenda. So thank you for bearing with us with quite a lot of information. I do appreciate your patience as we went through that report. Now, obviously, some of the other papers that we're going to discuss may well sort of touch base with some of the discussions we've had so far, but we'll carry on the rest of our meeting if that's all right. And then obviously there'll be time for questions later on as well. So if we turn back to our main agenda, we do start off by just checking if there's any apologies for absence. I don't know, Louise, Neil, if there's anyone else that you want to mention. I know our public health directors are unable to join us, unfortunately, for item 10.
Jeff Hurst as well, sorry, Mark.
Thanks, Louise. Obviously, if there are any declarations of interest in any of the items that we're going to mention, it'd be really helpful to hear those now. And I can declare that we are quorate. We do want to check that people are happy with the minutes of the previous meeting held on the 13th of July. I don't know if anyone has any questions, queries from those. Otherwise, it'd be great to hear if anyone has any other comments. Paul?
Yeah, just from the minutes. It's just we do need to agenda the feedback about deciding together, delivering together that we'd agreed. And the point that Joe raised as well about the ways of wellness coming back, so we need to agenda both of them for governing body meetings.
Okay, thanks very much for the reminder. And I think we'd said that the deciding together would be part of a sort of more up-to-date picture of where we are with mental health more generally. So maybe, Louise, you can remind me, but I think we've already discussed trying to get that agendaed. So apologies if we haven't been clear when that's being agendaed. I think it's at the next meeting, isn't it?
Yeah, I think both items are going to be on the actual development session, which will give us more time to discuss.
Fantastic. That's how we were doing it. Yeah. Great. So we haven't forgotten it, Paul, but thanks for the reminder. In terms of, so as I say, that's the mental health agenda and also the ways to wellness agenda, Louise. Yeah, fantastic. Okay. Any other comments on the minutes, or are people happy? In which case we'll move from the minutes and assume there's no matters arising unless anyone says. And obviously, Mark's already given an update in terms of the ICS through our presentation earlier. But Mark, are there any other items that you might want to highlight to the governing body of issues that they should be aware of?
So just a couple of things, Mark. First is the continuing pressures that the whole of the service continues to work under. And your colleagues in governing body will know far better than I just how pressurised the whole of the system continues to be. We continue to deal with COVID patients. We continue to deal with all of the various elements of the vaccination processes that we've got ongoing now. But underlying all of that, the demand for urgent and emergency care services is very high across the whole of the system. We are sitting here at the end of summertime, and it feels, in terms of the demand for our health and our care services across the system, it feels at winter type levels. So the whole system is running to try and deal with all of this demand. And I'd just like to say thank you to everybody for everything that they continue to do across all of those different agenda items, because it does remain a very difficult position for us to continue with. That said, we have our planning processes in place to deal with these things. We also have our winter planning processes in place to understand how we will continue to work throughout the year. And those are our normal kinds of processes. But I think it's just worth bearing in mind just where we are at this point in the year, so governing body members are up to speed. Thank you, Mark.
Thanks very much. So we're then going to move on to item 8, where we think a little bit about through the public and patient lens about any particular issues that have come up in that work. And obviously we absolutely prioritise engagement with the public around all the reforms and response to the issues raised. Can we pass over to Mandy and Paul? I don't know who's going to take us through this paper.
Hi Mark, I think it's me this time. So I'm
Brilliant,
Mandy. So I'm lay member for CCJ, and I'll pick up this and Paul can add anything that I miss. I mean, obviously we've got a tight agenda, but The paper highlights how much engagement's been going on, and also restructuring, Mark. So there's been a little bit of structuring to sort of like mirror the place-based commission and the preparation for ICS. But nevertheless, engagement continues, and going through the document, you can see that there's so much engagement around what our future is going to look like in terms of integrated care systems and sharing that with patients, looking what that's going to look like. We've had presentations from Mental Health Concern around sort of like what the mental health sort of like platform looks like across the city in terms of sort of like the ways forward and place-based commissioning. We've also got some mental health transformation consultation going on, which is ongoing, which is reassuring, and always a focus on our special education needs and disability work. And we've got sort of like engagement with young people, looking at how we can have the youth voice in some of our SEND work across the city. Again, that's ongoing, and consultation takes part with both parents and young people. I think in terms of Gateshead, the Gateshead Public Engagement Forum continues, and obviously it's now established sort of like within that different sort of like platform and system of sort of place-based engagement. There's been some work that's looking at the Gateshead community mental health transformation as well, and we're looking at some work being organised by Roots and Wings, which is looking at how we manage our task and finish groups within that work. Culture and awareness and engagement training has been ongoing. I think there's some real push towards sort of like understanding different cultural sort of needs and aspirations across the city, both in Gateshead and Newcastle and further afield. It's interesting that the Children and Young People's Partnership in Gateshead is also looking towards a children's strategy, which I think is really encouraging and inclusive, and involving young people in the development of that, which is really cool, and a kite mark that can be rolled out across GP practices. And obviously, just to finish on, because I know loads of people have read the report, the community forum continues in Newcastle. That's chaired by myself, and we had presentations by the police, the Office of the Police Crime Commissioner at the last meeting last week, which was talking about the Safer Cities agenda and safer nighttime funding that's coming on board in light of some of the attacks on women across the country, and how we can make our streets safer for women and girls, especially within parks across the city. So it was really encouraging to have that conversation. We also had a presentation by Lucy Williams around hate crime and trends across the city, because it impacts on our mental health and well-being, which was really informative. I think just to finish off, obviously the Little Orange Book carries momentum still, and it's been rolled out into its next stage, and it was mentioned and highlighted by the CCG in our forums, because it's really well received by parents, which want to look at the health and well-being and sort of like shortcut systems for self-management and sort of like self-help. So that this I remember being launched quite some time away, that was to help prevent parents racking up at A&E with very minor considerations and complaints, and it seems to be doing the trick. And also translation seems to be on the agenda there as well, so it's really encouraging that that's still going on, and will expand to maybe include young people as well as children. So again, it's been really busy. I wanted to thank you, put out a thank you to one of our Ashma Begum Hahad, who stepped in to be our our PPI sort of like consultant, while I've forgotten her name now. Was on leave. Christiana was on leave, pregnancy leave, and now is back. So just to say that Ashma was really informative, really nice to work with, and actually brought in the element of making sure we look at all different cultures across the city. So lots of work, lots of involvement, but also lots of anticipation about what the sort of like the thresholds and the sort of like the system's going to look like going forward. I have to say, from my point of view as a chair for some of the lay member and public engagement front facing work, there's lots of questions around, is this just another change, and what differences it's going to make? So I do think we need to be quite transparent in how we share the sort of like the plans ahead with our public and patients going forward. I don't know if you want to add anything to that, Paul, in terms of highlights from Gateshead.
No, nothing to add. That was good.
Yeah, happy to take any questions, Mark.
Thank you very much. And normally we have a comment normally by Paul that if we've ever used a three-letter acronym that he reminds us people might not know what that is. So I'm going to be really rude and say PPI, just in case people haven't heard of that. It's public and patient involvement. But anyway, apologies. Thank you so much, Paul, and for Mandy for all of that. Any other comments from anyone else that wants to mention that? And again, any comments from any members of the public?
Paul's still got his hand up. I don't know if is that historical.
It's to ask a question now.
All right, you go for it, Paul. I'm not sure you're allowed to ask a question about an item that you've been involved writing, though.
No, it's the thing about the British Sign Language. Point 13 on page 6. It's just that a lot of work has been done in the past on this as well, a few times. And it's good to see it come back in such a strong form to try and raise the issues again and get them addressed. Would it be useful to kind of do annual reviews and monitoring of this, just to make sure that the work continues and it doesn't have to keep getting reinvented every few years?
I'm sure it would be. I guess it's hard to pre-commit the next year's team on that, but I'm sure we should be trying to think of all those that are involved in the current system who hopefully will be those people involved in the future system. So yeah, I'm sure there are ways of doing that.
Cheers.
Thanks very much. We have a question from Shanaz in the chat function, just being really clear that the health visitors are still handing out and the school health advisors still handing out the orange books. I don't know if anyone knows the answer to that question. That certainly used to be the plan, that the CCG would pay for those booklets to be produced and ensure that they went to all of our teams. David, I don't know if you're best placed to answer that one.
Yeah, so it's just been updated. I think it's going to print either this week or next week, and then will be distributed to health visitors, midwives, practices, pharmacists, early years settings. So there's quite a wide distribution in anticipation, well, recognising the huge pressures at the moment and need to try and support the urgent care agenda. And as Mandy said, to get the book into the hands of parents and carers to help them manage their children's illnesses.
And David, do you want to just remind folk in terms of the online presence of that as well? Because certainly in the past we had a different online app and then there was an online version of this. I'm assuming that's been revised and available as well.
Yeah, there will be. As soon as we've got the final copy sorted out, there'll be an online link to the CCG websites, and obviously other interested parties will be able to direct to that as a sort of most up-to-date version of the book.
Fantastic, that'd be great. Okay, thank you very much for all of those. I think
Mark, just before you go on, I'm not going to let this go just before Paul. I know Shanaz has just put a well done, congratulations in the conversation, and I'm gonna. This is my conflict of interest. Streetwise has just won the Smith Kline Beecham Award in partnership with the King's Fund for impact on health with young people, and I think we should celebrate wins like that across Newcastle and Gateshead. It's a very, very highly competitive award to win, and one of the ones that really is a massive sort of I think amazing achievement for a small charity based within our CCG. So thank you, Shanaz, because I know Shanaz does a lot of radio work and promotional work as well for the work that we do in terms of engagement. So I'm not going to let that one go. Sorry, Paul.
No, I thought it was really important to mention, because I just think that the need for young people at the moment is greater than I have ever known it. And that, you know, they try to access services through things like e-consult and stuff, but that's challenging for them. But the fact that you're on the ground there, available, accessible, you know, and you can't put a price on that really. So very, very well done.
Thank you, Shanaz.
Well done, Mandy, and do thank all the team on all of our behalf. Paul.
Yeah, just to ask, have we got a target date for the orange book that's going to be produced for older children? I've not heard it mentioned for a while.
For young people, rather.
So there isn't a target date for that as such. I think there was some engagement work done with young people in Gateshead and actually in Newcastle as well to try and understand what they would want to see in a booklet. and that piece of work's being taken forward. So, and it's so we don't have a date as yet. As I said, it's ongoing development process around it.
Thank you. We've got Julia and then Joe.
Thanks, Mark. So I just wanted to pick up on the point that was made with regard to the pressures we're under, because the Little Orange Book is a critical component in supporting families and disaggregating parents that have got new illnesses coming forward. Because of what we had with the lockdown last year with COVID, a lot of parents that had babies last year, those children weren't exposed to the virus, and the parents weren't used to dealing with typical, unwell, feverish kids that would normally just take an hour strides. So we're expecting this year that we've got that kind of worried well cohort of parents, with the peak that we know is coming for RSV, the bronchiolitis type illness where young children need to be admitted to hospital, and then the routine COVID coughs and colds that we're seeing. So the Little Orange Book's a really key component in managing and separating out those different cohorts of young children that are unwell. So it was just to flag that. Thank you.
Thanks very much, Joe.
Yeah, I mean, I posted in the chat, it just gives parents, and particularly young parents, confidence in just managing minor illnesses. I mean, I would, joking apart, I'd even pay for an airdrop across Newcastle and Gateshead, in fact, the whole of the northeast. But I mean, generally, David, I don't know whether it's worth thinking, as we did for the How Fit booklet, to do widespread, postal door drop, because as I say, the How Fit really did go down well.
Yeah, I think the Children's Regional Network is involved this time in the development of the book and have supported it. So it could be, and there's a formal evaluation going on, because these things always take time, don't they? So there is something about, is there something more to be done here and now? And certainly that's something we can take back to the Children and Young People's Regional Network.
Yeah.
Okay. Thank you, Jackie.
Yeah, it was just to add a bit more to Paul's question about the teenage resource in Newcastle. The consultation outcome for that was that teenagers would prefer us to do it online, so it won't be a definitive day. What we're going to do is we're going to integrate it into the local offer, Paul, so that there will be a gradual increase in the signposting that's available. But actually, taking Joe's point, I think there's possibly something to do about publicising the fact that there are accessible links within the local offer. So we'll do that.
Thank you. Lynn?
Yeah, it's really interesting, the differences in geography, isn't it? So in Gateshead, and it's called the Teenage Resource, not the Big Orange Book in Gateshead, but our feedback from young people was that they would prefer a booklet. So really interesting. I think like the young people had said that, the professionals had said, they would probably prefer an online resource. So there was even, differences in those opinions, but we go with what the young people want. And we have got some funding from NHS England to print those booklets in a send version as well.
Fantastic. Thank you so much, everyone. So we will continue down our agenda, if that's okay. And I think we're going to pass over to Julia to start us off with our quality, finance and performance report, and then bring in Joe and others then. Julia, am I right? It's you to start us off?
Yeah, thanks, Mark. Neil, are you putting the slides up?
I haven't got the slides to put up, Julia. Is it just the report that went round with?
Do you want us to just talk to it? Yeah, that's fine. So I'll make the assumption that people have read the report and have it in front of them, and I'll just take you through. I'll not do a page at a time because some of it's you've heard some of it before, so I'll just flag some key issues if that's all right. So I'll start from a quality and safety perspective, the dashboard that's on page 6, and I'll just flag the ongoing work that we have with regard to the safe indicators that are on there, particularly with the healthcare associated infections. Colleagues will be aware that some of the requirements were stood down during COVID, but we've maintained that focus on safe services and seeking assurances through our QRGs. There is an extra item on there with regard to the GP patient survey, and it's fair to say that we've scored fairly well on that. Obviously, there's still work to do, and just to assure governing body with regard to the pressures in primary care, we're looking very much to see how we can be open and transparent about the many millions of contacts that primary care have with our patients, how we make sure when they've got an urgent care need that that's addressed through 111, and we don't have patients that bounce around the system, if you like. So we're trying really hard to make sure that every contact counts and that we get patients' issues resolved there and then, rather than referring them on to somewhere else and joining in the queue sometimes. So that work's really active and ongoing and being very well received by our patient groups in a positive way. Moving on to the next page with regard to our incidents and never events, I'll pick that up on the narrative. So I'll just skip through the next page up to page 9. So in detail from our HCI perspective, as I said, we have got those work ongoing with regard to implementation of standard processes and making sure that we're looking at the IT system that we need to focus on the data and improvement in IV line management and sepsis screening. So we've just flagged that on there. With regard to never events, we've already discussed these at a previous governing body. That was in regard particularly to an issue with cataract surgery for one. With regard to SIs, the number of falls and pressure ulcers that we have reported. What I need to explain with this is that some of this is related to COVID. So we know that patients who were COVID positive, it did cause these very micro clots in some patients, which then meant that they had some tissue damage. We know that when patients have falls, they sometimes have a what we call a long lie. So we've been trying really hard to understand for those patients that we're seeing with pressure ulcers, that we do that look back to understand how that's happened and if there's anything that could have been done to prevent that. So Newcastle hospitals, they've procured some different mattresses, for example, that have more protection for patient heels, and we've had a real focus on champions on each ward to make sure that that's being addressed. So in our QRGs, we've had a very deep dive into looking at those incidents, why they've happened, and if there's anything else that could have been done with that. I think with regard to mental health, the incidents look like there's a decrease in that, but again, there's a lag in the reporting through these, so we'll probably see that increase as we move forward. I'll move on to the middle of that page. You can see where we refer to absence rates, and all trusts were reporting above the England average for sickness rates, workforce pressures. So that's both in relation to people who were positive for COVID, need to get my teeth fixed, and the measures that were in place to support staff. But what we're seeing now is that significant impact from a mental health perspective and the number of staff that need supported with their health and well-being. So we've undertaken a whole range of mitigating actions to make sure that staff do receive health support and understanding their well-being, and doing everything that we can to make sure we've got that in place. But I think it's an ongoing challenge, to be honest, and I don't think we're, easily out of the woods yet with that. Complaints, we've had one complaint with relation to CHC funding decisions, and that's the norm with that area of work. And the other complaints that were received were passed through the appropriate organisation, but obviously we still monitor that as a CCG too. I turn to the bottom of page 10 now, the 12-hour trolley weight breaches. Sadly, these occurred at Gateshead hospitals, and I think it's fair to say that that's the first time this has happened, I want to say in about 5 years. So we had to kind of check how it is that we report and manage these, because it's so long since it happened. To give assurance to governing body, there was no patient harm, so that meant that they were supported, they had food and drink, etc. But I think understanding the pressures that we have in the system, that this was the end result with this significant trolley breach. So we've alluded to the factors that we've undertaken that rapid review, and these were the initial findings. So we had a number of staff. It was at the point when people were referring to the pingdemic, if you remember. So there were a number of staff that were having to isolate following the track and trace contact. There was an issue with domestic staff in relation to that, and they had staff that weren't able to operate the UV cleaning systems. So we're really thankful that Newcastle Hospitals in Northumbria and North Tees actually sent staff and the equipment to get the wards cleaned and the beds reopened, and that then helped with the flow to reduce those delays. So they were the initial findings, and obviously there's a full root cause analysis that we undertake with that. I think it's fair to say that the 4-hour A&E target has been breached a significant number of times, again due to the system pressures and the number of patients that we're seeing presenting just now. With regard to the next page, on page 11, there was a major trauma review of NEAS, and there was some concerns raised within that. However, when we've given some feedback, it was understood that there'd been a bit of a misunderstanding with some of the pre-hospital standards, and we convened a system-wide review led by the Northumberland CCG's Directors of Nursing as the lead contract for CCGs, and it was understanding, as I say, that situation. So I don't think what was initially flagged was found to be factually correct when we did that piece of work. So that was good news. Moving on to 111, as I've flagged already, system pressures. So we've recruited additional call handlers into the 111 service, but they were flagged as an outlier in December for call abandonment rates, call pickup times and call back times. So there was a meeting that was undertaken with CQC, again with the lead commissioner for NEAS, and an understanding of what was linked into that. CQC are involved, and we've got a summary of that data. But we've tried really hard to work with NEAS and colleagues to make sure that both for 111 and 999 call answering capacity, we've maximised that where we can to make sure patients get that appropriate response, which is obviously really important. The final point on that page is the hospital standard mortality rates, and again we're looking to do some significant work on that. It's understanding the data technicalities, because it looks like initially the first data we had that there were an outlier, but then we got NEQOS to do a deep dive, and that hasn't identified any significant concerns. The impact of COVID is still being played out, as I said, and it looks like that'll play through. So it's something we're keeping an eye on and being really robust in scrutinising that data and make sure we're sighted on that and what needs to be undertaken as a result of it. So that's a quick canter through. I don't know in terms of pressures that I've alluded to, if anybody's got any further questions on that, I'm happy to answer.
Thank you so much, Julia. People are welcome to come back with questions later on if they think of them. Are we passing over to you, Joe, next?
Yes, thank you, Mark. In terms of the finance and performance sections of the report, if I can just quickly deal with the money. In terms of the financial position set out and contract position set out on pages 29 to 40, it's perhaps best summarised that we envisage for H1, the first half of the year, to hit our financial targets with a surplus of 1.2 million. As I said earlier, the COVID financial regime and contracting regime, where we're seeing block contracts, we expect to remain in place for the second half of the year. The funding announcement we are expecting sometime this week, if it hasn't already arrived as we've had this meeting. So overall, I think financially the CCG is certainly in a good place for the first half of the year and expects to be so in the second half of the year. Turning then, if I may, to just spend a bit of time on the performance section of the report on pages 13 to 28. And it's already been alluded to many times thus far about just how much the service is under pressure. And emergency care, COVID, winter recovery, these are all significant asks of the service, let alone each one of them is, let alone all four together as we go forward into winter. I mean, we are seeing performance levels, as Julia's already alluded to, that we haven't in events that we haven't seen for such a long time because of the pressures on the service. And performance is always an interplay between sort of demand and capacity. But in terms of what we're actually seeing, at North we have over 5,000 52-week waiters and around 120 waiters who have actually been waited for now longer than 2 years, with particular problem specialties being spinal, ophthalmology, and we are seeing some pressures in unexpected specialties such as cardiology. In terms of gated, similarly, we have a number of over 52-week waiters, 43 in total, predominantly in the orthopaedic specialty. Just in terms of other points of delivery, diagnostics, we are seeing longer waits at both of our hospitals. At Newcastle hospitals, it's about 20%. At Gateshead, it's about 30% in terms of patients who are not being seen within 6 weeks. The normal standard is 1%. Bill, you want to come in at this point? Presumably it's around diagnostics.
Not diagnostics as such, but it's related to the previous comment, Joe. I think it's useful for the lay members and the members of the public to understand that whilst the metrics that you've talked about, the long waiters, the over 104-week waiters, whilst they're pretty disappointing to say the least, we haven't been watching this. We've been doing things about it. There's a spinal task and finish group, which is an ICS-wide group, which meets in such a manner that we can get a plan across the ICS. There's an ICP-wide issue with ophthalmology that we're working hard on. So it's not as though there's a level of inactivity there. And I think it's important to get it on the record that both providers, commissioners and interested parties are doing what they can to reduce this unacceptable level of waiting.
And Bill, do you want to just say something about the cancer initiatives as well?
Sorry, I've only got about 4 hours available. It's really difficult at this moment. I think Mike's already alluded to the fact that there's a higher than normal level of absenteeism in our providers. We are pushing all the time to deal with the staffing issues. The cancer waiting times have been compounded by people unwilling to come forward initially, and then the rebound afterwards, which has caught us in a difficult position of not having capacity to meet the demand. People are prepared to do extra waiting times, and the diagnostic services will become overheated, as you alluded to there. If effectively, we are looking very closely as to whether there's been any what we call stage migration, which is whether any delays have translated into people being diagnosed at a later time in their disease than they otherwise would do. As soon as those data become available, we will publish those. The other thing to say, and everybody's heard me say this before, never let a crisis go to waste. We've actually put the clinicians together across the ICS in matters of diagnosis for endoscopy and therapy for other services, so that we can manage out the variation and even up the services that are offered across the board, so that we don't have islands of really good care in a sea of mediocrity. So if that sounds like platitudes, it's not. It's actually people working really very hard to overcome the problems that have been thrown up. But the upside of it is that clinicians are working closer together than they ever have done, and that will reduce variation for patients going forward and minimise postcode lottery.
Thanks. But just a couple of further points of interest. Of the long waiters, over 52-week waiters, 270 patients have said they don't want to come forward for surgery at this point in time, but they still want to remain on the waiting list. So again, it's another aspect of COVID that we're actually seeing in terms of service delivery. And again, just as a matter of record, just to finish on the performance, whilst the service remains incredibly challenged, it's probably fair to say that the hospitals and services we have in the northeast are some of the best in the country. And some of the amazing things that are happening and efforts on the front line wouldn't be able to happen without the support of all the staff right across the service. So again, it's a measure of just how much the system is under pressure. I'll stop there, Mark, and again through yourself, invite questions.
Thank you so much. And there's so much information in there. And as you rightly say, whilst there are areas that we absolutely would not want to be the way that they are, that doesn't mean there hasn't been huge amounts of hard work to make sure that they wouldn't be worse, and ongoing hard work to try and improve and restore those within the controls that we have. Clearly, the demand has been the real challenge that we haven't been able to control, even though we try and do the best with what we have with our services. Are there any questions that people want to mention? Can't see any hands going up at the moment. In which case then, and we'll just check members of the public, any questions that you wanted to ask for this section? In which case we will continue. We don't have our members of the public health teams with us today. This is a one-off. We hope that will be restored on our next meeting. We do, however, hope to have some sort of update arranged from colleagues of key issues that are happening in public health. As I say, it's unfortunate that we haven't been able to align diaries for them today. In terms of our next section, section 11, we have our Workforce, Human Resources and Organisation Development report, which is back to you, Joe, if that's all right.
Okay, thank you, Mark. Once again, I take the report as read, but just a couple of highlights, if I may. In terms of new hires and new appointments, we've had 13 in the first quarter, and 6 staff have left the organisation. And it may well be that just the way, particularly sort of agency staff, some of those new hires may also be some of those who have left in a quarter. It's just in terms of just short-term employment. In terms of sickness absence, and particularly the short-term sickness absence rate has improved from the previous last quarter. But the long-term sickness absence rate, we are seeing an emergence of S10, which is mental ill health, as a primary cause of long-term sickness absence. So as a management team, we are actually internally focused on mental health and mental well-being in terms of supporting our staff. And the report sets out some of the initiatives and engagement we have with our staff in terms of health and well-being, in particular mental health. And some of the staff sessions have been focused on mental well-being, in particular mindfulness sessions. We had the staff survey from last year, and we're just embarking on the survey for 2021-22. But in terms of some of the reports and issues that staff raised from last year, we took an internal exercise, a temperature check exercise, in which we asked staff in a number of sort of key lines of inquiries around sort of health and well-being, climate change, motivation, and working in a COVID environment, just how as an organisation and as a management team we were doing to support staff. And under section 7, I've enclosed some detail in terms of the feedback. And it's probably fair to say, whether it's the bar charts we see under the various subsections in section 7, or whether the word clouds or tag clouds, we can see we are showing signs of improvement in terms of staff feedback. We do have staff sessions every fortnight in terms of formal feedback, and across the various areas and key lines of inquiry, you can see from there what staff are saying to us. Interestingly, again, some really positives I found in terms of motivation and team working despite the challenges of working remotely. 65% of staff felt positive in terms of their current way of working, notwithstanding the changes ahead in terms of the ICS. And whilst in staff sessions we don't have many of the answers to the questions that are being raised just because of the point in time we're at, nonetheless, I think, again, staff are genuinely grateful in terms of the engagement that they do get. The other point again to raise perhaps with the governing body is how staff are viewing return to work in the real working environment. And again, the report outlined some of the apprehensions that staff have in coming back to work in a COVID safe environment. I think we need to strike the balance in terms of remaining and keeping staff safe, but also just thinking about some of the mental health issues that working remotely is presenting staff, and our engagement with staff on a regular basis is intended to keep staff sort of engaged and in a social environment. But in terms of, again, just a process for returning to work, Neil and Hilary are working closely with Lee and Nex in terms of safety and COVID safe environment. But as I say, we are not, there's no haste to get back to work, and we are very mindful of sort of government advice, but equally what staff are telling us that about their apprehensions about returning to work, and we will end up with a hybrid bundle at the appropriate point in time. I'll stop there, Mark, and just invite any questions.
Thank you so much, and so much hard work by so many in very difficult circumstances. We continue to evolve our support, but as I say, there is so much going on to support our staff, and lots of positive feedback about that support. Thanks, Joe. In which case, if there's no questions about that one, the one will then pass to Mark, who's going to give us an update about the integrated care system. Although, Mark, you may have already covered this in our annual update, so there may not be much to add.
Thank you, Mark. So we've already covered this a couple of times at various points on the agenda. So I'm going to take it that governing body members have had the chance to have a look at the documentation. So I'll just restrict my comments to just pointing out a couple of things if I could, Mark. So, and I think most of those are around next steps, so colleagues have a clear view about that. So, as we've already mentioned, work is now underway in earnest to get us to the point where we're in the right place for the 31st of March. And as we've previously discussed, Sir Liam Donaldson held 4 ICP engagement events earlier in the year in July. That work has helped inform his view of the world in terms of our strength in depth about ways of working at place and our maturity about ways of working at place. And I think that gives him a platform then to think about the design of the ICS per se. The next stages of the ICS design will focus around a design group that he's bringing together, which has local authority colleagues on it and has NHS colleagues. And that is looking at 4 meetings over the next 3 or 4 weeks. And the outputs of that will be to develop proposals about the composition of the Integrated Care Board, the Integrated Care Partnership as key elements of the Integrated Care system. And also recommendations about ways of working and ways of working with the place-based groups we've got and how those governance arrangements will work. On the 19th of August, NHSEI published a model constitution, and you've got details of that in your packs. I'm not going to go through that in any depth or detail, but just to say that that is there, and that will be part and parcel of the work that Liam is now focused on. Just in terms of our roles as the sending organisations to the receiving organisation, which is the new ICS. So we will transfer our responsibilities from CCGs to the new ICS. The Health and Care Bill does require the CCGs to formally propose the ICS constitution to the Secretary of State ultimately. And that's because the CCGs are the outgoing statutory organisations. The ICS is not a statutory organisation till it comes into being on the 1st of April. So it is the CCGs and actually the governing bodies as the proposers that will take that work forward. It's also the case that we will work through a process as CCGs of due diligence in terms of assuring ourselves about the process of transfer and assuring ourselves about the ICBs being in a place to be able to take on board all of our responsibilities. There are already a wide range of checklists, due diligence checklists available, etc., that we're working through now, and we will work through those processes to make sure that we are closing down our organisations in a fit and proper manner, and we're transferring our responsibilities in a fit and proper manner as well. One term you will start, I'm sure, to hear as we continue through these processes are ROSs, which are readiness to operate statements, and that is the ICB's readiness to operate and to accept the responsibilities from the CCGs. I've already spoken about appointments, but there is something just to consider in terms of governing body involvement in decisions. As I've already said, we will be required to propose that constitution, and we need to look forward to, and we will look forward to receiving formal updates now as this process moves forward from Salim and colleagues at the ICS. So one, we can assure ourselves that we are part and parcel of the process, but also we can ensure that we are playing our part as the sending organisation to the new ICS. So I'll leave it there, Mark. The recommendation on this paper is for governing body to note the progress to date, but I'm very happy to answer any questions if governing body members have them.
Fantastic, and I suspect there'll be many different reports and many different papers as we go through our future governing bodies that provide bits of the detail as we start to know it. Obviously, we're really keen to try and help direct the way that the ICS can serve our communities, and so we're very keen not just to wait for future guidance, but to keep feeding in. And I know a lot of our work at place-based conversations is trying to do just that. So thank you very much to all those involved. Thanks very much for that update, Mark. We're going to move on to section 12, unless there's any other questions.
Mark, I've got a question.
Go for it.
I'm the only black woman sitting in this room, and the ICS, people involved in the ICS looks like very white snowy peaks to me at the moment. And that worries me with regard to echo chambers and, you know, collective blindness stuff. And if you think about how big the region is, and if you think about the population that we serve and the demographics within that population, I don't think the ICS reflects at all that demographic. And I think that's a message that needs to be taken back, because I think and that we need engagement from different thinking to influence the birth of this new organisation, and I don't see that at the moment.
Thank you so much, Shanaz. And as you say, there's a whole engagement exercise with lots of different parts of our region that this ICS should serve. I know that's a very difficult message to say, and thank you very much for being brave and saying it, Shanaz. But as you rightly say, I think there's been a lot that's probably a bit more inward looking at, and absolutely the engagement with wider communities. I don't know, Mark, whether you're able to feed that back. I can certainly do in some of the meetings we have in a few weeks.
So I'm certainly able to feed that back, and I think a couple of things. One, the whole direction of travel in terms of ways of working, it's very much about inequalities, but it's also very much about diversity and inclusion as well. So we hope to see that shine through the ICSs as they start to get put in place. It's also the case that the national recruitment processes that have already been kicked off, they've been specifically designed to be as open, as inclusive as they possibly can be. So we hope to see some of that come to fruition as well as we move forward. But we'll certainly take those messages back, Shanaz, and thank you for raising it.
Thanks. Julia and then Joe.
So, Shanaz, I completely agree with your comments, both as a woman and as a colleague for the Black and minority ethnic group. So I just wanted to give you assurance that we've got a huge amount of work with the Directors of Nursing Group. So Annie Toppin is supported, I think she does 2 days a week with the regional Directors of Nursing and feeds into the national group, and she presented some slides on Friday from that strategic group on the work that's underway, both raising the profile of nursing as a professional group, but how we get grassroots staff involved in championing the Black and ethnic minority activities that are underway. So I'll share those slides with you offline so you can just get a flavour for what's happening. And I know that Margaret Kitchen leads that work, and Margaret's integral to the recruitment of the staff who will be at that ICS board level. So hopefully we'll have been able to give some of those messages.
Thank you.
Thank you. Joe, assuming that your hand going down means that that point has been covered, but feel free to put it back up if you, yeah, okay. Thank you very much, Shanaz. Thank you for all those points. Any further comments before we go back on to item 12? And this is the risk register report, and over to Neil. Neil.
Thanks, Mark. I'll be very brief because this reporting period, there haven't been any significant changes to the risk register. So we've done the usual process of looking at all the risks with risk owners to make sure that they're scored appropriately and whether we need to change any of the controls. But actually, there hasn't been anything significantly changed this reporting period. I'll just flash up one slide from the presentation, if I may, just to illustrate one of the changes that we've made. So this matrices that we've got on screen now, we talked about it last time, but this is the first time we've kind of transposed it to the new risk scoring matrix that we've got. So we've got red, amber, yellow and green now. So this is a slight change to our policy, which brings us in line with NHS England approach, and also the rest of the CCGs in the patch have adopted this risk matrices now. So what that means, it's been transposed to a different matrices. Some of the scoring or some of the colours have changed, if you like. So there'll be a one-off change to some of the scores you'll see through the risk register. But actually, the scores and the risks themselves, with no new risks added and no changes to the score. And we haven't closed any risks this reporting period. But I just wanted to flash up the matrices because you'll see this going forward and not just the red, amber, green that we used to have. Just close that down for now. That's all I wanted to mention.
Okay, thanks very much, Neil. Any questions for anyone on that one, including any members of the public questions? In which case, then we have a variety of items for information, and I'm assuming they are all just to be read. And if anyone did have any comments or questions about any of them, now is your last chance of questions from either members of the governing body or members of the public. Otherwise, I think we have gone through the rest of our agenda. We have the date of our next meeting on the 30th of November, and obviously any comments about other items that should be included, please do let them know. Do let Neil, myself or Louise know, and we'll try and make sure we can add them onto our future agendas. Can I thank everyone for coming today? Particularly thank you to members of the public for coming. I always quite like to ask if members of the public do feel brave enough to say if they found any particular parts of the meeting helpful or bits that we should do in a different way. If you did feel brave enough to offer your thoughts, they would be most welcome. They don't have to be done now, but any members of the public that do feel free to let us know at a later date, that would also be really welcome. In which case, we'll say thank you so much for everyone's hard work. Thank you for everyone's points and discussion today, and we'll say goodbye for now. Take care, everyone. Bye-bye.
Thank you, Mark. Bye. Bye.
Bye-bye.